Everybody. Okay, so we're going to kick off. I'm just going to pop into the top of the chat where people can access the recording if they want to click through there. And also, there's a couple of links to Laura's upcoming courses. So if during the session you want to check those out, you can click those links straight through. Fantastic. Okie dokie. Here we go. So, a very warm welcome to this NOI Group clinical discussion. My name is Joanna Taylor and I am Director of NOI Group Europe, and I am joined this afternoon by NOI Group teacher and my very, very good friend, Laura Rathbone. Welcome back, Laura.
Hello.
For those who have missed our previous sessions, Laura is a pain specialist clinician and mentor to healthcare professionals worldwide. She brings a unique perspective, combining cutting edge science with compassionate, inclusive practice. Laura, it's great to have you back. Could you just remind us a little bit about what you are doing professionally?
Yeah, so I'm a pain specialist physiotherapist in complex and chronic pain, and I work psychologically informed by acceptance and commitment therapy. My current role is as a consultant in pain to the OLVG hospital here in Amsterdam in the Netherlands, which is just lovely. Um, Alongside that, I also facilitate and train multidisciplinary clinicians on acceptance and commitment therapy, particularly aimed at non-psychologically trained clinicians. So it can give you a good, I guess, a good framework for using a psychologically informed approach. And I'm a clinical educator, an activist for social justice in pain care, and together with my friend Christine Petridis, I run Pain Geeks. And Pain Geeks is an international reading community where we focus not only on supporting clinicians to get a sort of a wider and deeper understanding of pain, but also we are really sort of like committed to supporting people to improve their critical reading skills, their academic skills, so that when they are reading something, they get like more bang for their buck. They're able to filter out what isn't useful, what is useful, and like, oh, that's so lovely that you find Pain Geeks amazing. I also find it amazing. And like the most important thing is that it is a like really it's a community. And actually the main reason that Pain Geek started was like just I sometimes had felt so isolated as a clinician trying to understand this really complex science. And the thing that helped me the most was finding a group of people to talk about it with. And so I thought, why not do that, but in a sort of like a more organized way so that people who don't just have access to like the NOI faculty, for example, or like, one of my long-term mentors is Professor McThacker. If you can't just get hold of those people, how do you start to work your way into the pain network, which can feel kind of elitist and exclusive sometimes? So that's what Pain Geeks is about.
It is, makes it accessible, doesn't it?
That's the idea. And
Yeah,
it's like
fantastic.
supposed
It's
to
a great
fit.
community. Drop the
Yeah.
link.
Oh,
Don't forget to drop the link in the chat because on our previous sessions, a lot of people have been in and joined the free membership. So please do
yeah.
get yourself over there.
That's been
Fantastic. Thanks,
amazing.
Laura.
No, thank you.
So these sessions are all about giving you a taste of explain pain and how to practically use it in the clinic. Some of you will have done an explain pain course already, and for those of you who have, these sessions will reinforce what you've already learned. But if you're new to explain pain, this will give you a little taste of what we cover in the core course. Laura's got two courses coming up, an online course starting October and a face-to-face course in Dublin in November. And so for anybody that's interested in learning more about those, we'll be giving some more details at the end of this session. So just before we kick off, Laura's going to be talking for about 20 minutes. If you've got any questions, please put them in the chat or the Q&A. We'll get to as many of them as possible. Don't wait till the end because we will run out of time. So pop them in as we're talking and we'll insert them into the conversation if we can. And if you want to watch the recording of this session, it's available on our YouTube clinical discussion channel, where you will find the recording of this, plus about 50 other sessions with a whole range of the NOI faculty on a huge spectrum of topics. The idea is that when you do a NOI course, you're fully supported beyond the classroom. We don't just leave you. So get yourself in there, check them out, subscribe, and then you'll be notified when we upload new videos. So today, let's kick off. We are talking about how to motivate patients with chronic pain to exercise. So, Laura, what are you going to talk about?
So, first of all, I love the title of this because I think it's something that lots of people struggle with. But I would say that I take the approach that we can't motivate people. Motivation is an intrinsic experience, right? So, what we're trying to do is create enough space and safety for someone to feel more motivated towards something that they've already said is what they want to do. And so, I guess today we're going to talk a little bit about that and how to what kind of skills can we facilitate and nurture as clinicians in order to create those optimal environments for our patients to allow their motivation to bloom, I guess. Yeah.
Fantastic. Thank you. So let's start with the reality that many clinicians face. We know that exercise is evidence-based for chronic pain, yet so many patients resist it. Why do you think that traditional motivation approaches often fail?
So I think we need to talk a little bit first of all, sorry to go off on a
No, it's
tangent, but
fine.
like when we say something like evidence, like exercise is evidence-based for chronic pain,
Mm,
there's a little bit of like work that needs to be done here around the question because on the one hand this is kind of obvious, but then on the other hand it sort of isn't, right?
mm,
So yes, it's evidence-based as in, there's like plenty of research out there that is trying to help us understand what the role of exercise might be for individuals. But we don't really have like a fixed definition of what exercise is.
mm,
And I am not a strength and conditioning expert. So this is where I also need to say there are limitations and gaps in my knowledge.
yeah.
Um, but from in terms of there's been this lovely 2017 Cochrane review that says that sort of physical activity and exercise for chronic pain is sort of weakly supported by the evidence, right? So there is an evidence base that does sort of weakly support that we should be encouraging exercise with chronic pain, but it doesn't show the same sort of evidence for sort of the psychological measures and the quality of life measures didn't move in the way that we would have hoped. So, yes,
Right.
there was sort of like some evidence that some people in some of the groups did get a lower severity in pain, but nowhere near what we would hope for. And there's some real methodological issues. So, we have some evidence that supports this, but we need to be careful when we say it's evidence-based, right?
Okay.
Because there's some controversy within our evidence base when we go to look at it. So, but there is this, and there's also this other problem as well, because we have this kind of cultural idea as to what exercise is, but that can differ depending upon the person, who you are,
Mm,
and your life context. So, for example, like I might consider dancing exercise, but for somebody else, it might be climbing up and down their stairs twice a day. So we need to sort
mm,
of, this is what I've talked about over the last few weeks as well. Like sometimes we need to calibrate on the language and think about what sort of opportunities does the words we use open up in the space between us? And exercise could be a very opening word, but it could also be a closing down word. And it might be
mm,
that what we're actually trying to improve is movement and we're actually trying
yeah.
to improve function,
Mm,
where an exercise might not necessarily be what we're actually trying to encourage. So I think there's something that we need to think about from that perspective. And then we also need to think, okay, are we trying to do something that is fatiguing or are we trying to do something that's regular? So are we trying to use a sort of S&C approach where we're like, okay, we need to increase the load beyond the capacity so that we promote strengthening? Or is
mhm.
it that we're actually wanting to think, okay, well, if are more like a graded exposure, let's just get some regular movement in so that we can start to um, habituate your system to just doing a bit more than it was doing yesterday. So
Yeah.
these are the things that we need to consider when we're thinking about exercise as clinicians.
Mm. Do you
Then,
prefer to use the word movement
yeah.
generally? Yeah, I think a lot of a lot of our colleagues do, don't they? Yeah.
Yeah, absolutely. And I'm not for any, like, I think many of the people on this call would already really recognize this
Mm,
conflict that we have. Much of the exercise-based evidence, like, isn't necessarily focused on the chronic pain population. And it's not directly translatable from a sort of general MSK post-surgical orthopedic situation or strength and conditioning for specific gains within a specific movement. Like
mm,
there is something very different happening within the biology of people who are having a daily experience of pain or chronic pain over many years. Maybe we might see
mm,
shifting in their neuroimmune system. So, like for example, if you look at some of the really lovely work by Kathleen Sluker, who's just a prolific writer on this, she's shown that okay, in sedentary mice there might be an overexpression of some of the NMDA receptors, which might be responsible for why there might be like if we could translate that directly to humans, which we can't at the moment, but if theoretically we did, then it might help us understand why there's a higher experience of pain with an increase in activity. They might just be more
mm,
sensitive to movements, more sensitive to the sort of inflammatory mediators that are around. And so and then equally, she shows some evidence that if we're exercising regularly, we might be able to shift into a more anti-inflammatory system. So there
mm.
is some sort of biological plausibility, but but it's how we introduce it that might be important and why we think that's important as well.
Okay.
And I think one of the problems we have is that sometimes in a sort of traditional approach, we don't necessarily take all of that into account. It might just be, you know, more is better. Exercise is good because exercise is good. And that's a circular argument. That's not an evidence-based argument. It's a moral judgment. And actually what we're trying to do is evidence-based healthcare for people who have a very, very distressing and disabling condition or
Mm,
experience in the world. And we might have to take more into account and think more about how do we improve, how do we change behaviors? How do we yeah, I guess that's where I'm going with this. Like, how do we build a good therapeutic working relationship so that we can support people to put change into their life where that is meaningful for them, and then we can help
mm.
them to do that in the most evidence-based way?
Okay. Okay. So, why do you think that the traditional approaches fail with the chronic pain
Right. I think it's because
population?
they just don't take it doesn't take the complexity of that into account. It's more
Yeah.
like, okay, you've got chronic pain, therefore you need to exercise. And it's kind of a sort of like there's a kind of almost like a lack of relationship required like that's being built for that. And for some people when we're asking them to do exercise, it might be that there's a significant amount of like past experiences. It's very
Mm,
likely that they've been told by therapists before they need to do more, right? And that might make their pain significantly worse. So this isn't a motivation issue, this is just a lack of
yeah.
congruence. It's a lack of understanding the person in front of you. And I think, the most important thing to remember is there is nobody more motivated in that room than the patient, right? There is nobody more motivated to change their experience of pain than the patient. So is this a motivation issue, or just is this a very difficult but understandable in some ways, but a very difficult problem around introducing movement, making it meaningful,
Mm,
understanding the experience of the patient, being pain science informed so that we can be careful with the people who are very vulnerably sat in front of us asking for help.
yeah. Yeah. Great. Thank you. Um, so what are the most sort of what are the most common fears that you see, and how might clinicians work with these without overstepping into psychological therapy?
Yeah, so I think what we see really commonly is that people are afraid of making things worse.
Mm,
And I think that's a very understandable fear when you're living with chronic pain, any kind of chronic pain, really, where movement seems to be one of the main aggravating factors. It's like nonsensical to move if that's your main aggravating factor. And so one of the things
Mm,
we have to support is either how to change your relationship with that fear or how to work in other ways that doesn't just keep butting up against it over and over, because then that's just setting everybody up for failure. And that's not, it's just not kind, really. So
mm,
I think that's one of the bigger fears. Um, and I think that's something that we have sort of ways of addressing. So there is a difference between, true kinesiophobia, which is the construct by Corey Miller and Todd, that's like this idea that people are really afraid of movement,
mm,
and phobic of movement. And then there is sort of fear of movement related pain. And they can, we can of course fear of movement related pain is part of kinesiophobia, but it's not sufficient. And what we want to try and
mm,
figure out is this a fear of movement, in which case we really need to apply our therapeutic approaches to exposing to different movements and understanding why there is a fear of movement. And this is quite common after surgery, right? So people are
right.
just afraid of movement, afraid of using that body part. Or is this fear of pain, in which case we're looking to change and support the person's relationship with pain in various contexts, and then we can sort of cross apply that to the movement.
Mm,
So I think these are really helpful ways of thinking about fear, I guess, and about what we're seeing in front of us.
yeah.
And I think this is important because if we're working biopsychosocially, we need a model of behavior that incorporates thoughts and feelings and emotions. And um, I think the nicest one that I would recommend for people to look up would be McEwen's allostatic loading model, which is sort of acknowledging that that thoughts and emotions and feelings can provide physiological load, right? And that in a
Mm,
in a system that is I don't know, experiencing chronic pain, so it's got some processing changes. It might be more sensitive to some things than others, more likely to give a pain experience than others. That might help us to understand why
mm,
um, somebody may well be motivated but afraid, and how we can work with that and how we can change the loading pattern. That doesn't just mean changing the movement. So as a physio, when I say change the load, I'm thinking about repetition, I'm thinking about weight, I might be thinking about context or lever. Whereas like if you're thinking more from an allostatic position, you might be thinking about environment, you might be thinking about stress levels, you might be thinking of
mm.
whether somebody slept the night before. And so when you're thinking about load in that allostatic framework, you're thinking much more whole person and integrated. And I think that's super helpful.
I don't want to put you on the spot here, but can you think of an example where you've sort of gone through this process with a patient? That's really usually really helpful for our audience.
Yeah, so I've got a patient right now that I'm working with, and I don't think she'll mind because she's normally very open to me talking about her situation, but I will change it slightly. But she's had some surgery, some spinal surgery, which was preventative, and we're now in a situation where she is kinesiophobic of certain movements of the spine, but there's also just significant amounts of anxiety. There's also like she's also experiencing changes in mood, her sleep is bad, the social situation has changed, and sometimes she comes in
Mm,
and she's just had a really bad week. And I'm like, okay, well, we're just going to alter how we work with this. And so we're not going into the high level movements, we're going to adjust the load because I want her to succeed. And because she's afraid of movement, we're working on experiencing movement with different contexts. So, for example, if the fear is in rotation, then we might do body rotation, but we might do that in sitting whilst watching something or trying to change the load of the
mm,
experience rather than only thinking about the load in terms of numbers and weights. And so
yeah.
it's that kind of exposure-based principle that we're using. Does that
Okay.
make
Thank you.
sense?
Massive. Yeah. Absolutely. That made sense completely. Well, that sort of brings us on nicely to the next question, which is if patients have had negative experiences with movement, how do you help them to separate past experiences from current possibilities?
Yeah, I mean, this is where you're starting to use this is where I lean heavily on my psychologically informed sort of principles. And I think
Mm,
about, okay, well, first of all, acknowledging the fact that they've had these experiences and that they are in control, right? Like, I'm not
mm,
going to push them to do more than they feel they're comfortable with because, like, really, if I only have one way of helping this person improve, then I'm not doing a very creative job as a clinician or as a therapist, right? Because there's so many different ways that we can support people. So sometimes I notice like I get quite stuck, like we've got to improve range of movement in this, but actually the pain is a way much bigger experience, and it might be that we just can't work on that right now, right? It might be that we have to work on other things. That where there's more opportunities for success, more opportunities for change, it seems like it comes with less resistance. Like that's not avoidance. Well, maybe you could, maybe I could be called on that a little bit sometimes, but it's more like, yeah, if this person has agency over what we do, if they're
mm,
saying, I've had terrible experiences in the past, as soon as you give me exercises, I know I'm going to get worse. Like, if I can't think of anything else to support this person, then I probably need to take that person into supervision because I've got stuck. And there are so
mm,
many other ways to help people. So that's one of the things that I would say. I would take it very seriously. They know their body better than I do. They know how likely it is to respond with pain. That's valuable evidence of this person's experience. And so there's no reason for me to discount that, right? I'm going to
mm.
incorporate that. Um, and then, if we think movement is really important, then we might spend more time rather than focusing on what to do more. What are you doing right now? How often are
Yeah,
you doing and even just observing that can sometimes open up opportunities where they say, oh, well, I can do a bit more of this, or I can do this a bit more regularly, or actually that feels good. And they can sort of find their own solution to doing a bit more. And the whole point of behavior change is, can you do something different tomorrow from what you were doing yesterday in a
yeah,
helpful, meaningful way? And I tend to take a behavior change approach to what I'm doing. So for me, that's enough. Um, yeah, and thinking about and this idea of like moving away from exercise and thinking more about exploring movement. Can we
yeah,
hold this a bit more lightly? Can we put a bit more play into this, a bit more joy into this, rather than this being another job you have to do in order to manage your pain?
yeah,
Um, is there actually some joy in some of the movements that we can start bringing in? And wouldn't that be lovely? Because, we often frame people as human beings as being threat averse, right? Or threat avoidance, like we're constantly working on avoiding threat. Like that's only one way of understanding how our complex biology supports us to live and thrive in the world. But we're
mm,
also pleasure seeking, so we also
100%.
we're also often always looking for ways that we can engage in the world that brings us this sense of, positive valence, this positive sense of who I am, and sort of satiation. We want our needs to be met.
Mm,
And so a movement is a great way of exploring that because often, like there can be negative experiences with movement, there can often be very positive ones. And sometimes, rather than trying to avoid the negative ones, we can move towards the positive ones.
yeah, a great
Yeah.
answer. Thank you. We've got a question here from Sophie. Thank you, Sophie. Great question, great timing. How would you advise patients on when an exercise may be too intensive currently and requiring reduction of load and or intensity in those with, I can't pronounce that, kinesiophobia.
Kinesiophobia.
Kinesiophobia, well done. I like to use a 4 out of 10 pain threshold score for them to use, but how would you approach it?
Yeah, I mean, for me, like there's no sort of standardized way of doing this. It's really what can the person in front of you use for themselves, as in this is something I can get to this level and I can probably have a pretty good day. Or if I get to this level, then that's it, I'm done for the next 3 days. And it's like, I don't really mind what that looks like. I just mind, is that okay for you? Right? Is that
Mm,
okay for you? No. Okay. Well, then it's not okay. So let's move on. And I think sometimes with some patients, there is a tendency to and this is partly our fault as healthcare professionals and also the sort of the toxic wellness field that's out there. There is this idea that if you just work harder, if you just push harder, you will not feel pain because pain is a punishment for being sedentary. Pain is a punishment for being overweight. Pain is a punishment for not, and that's a very old sort of religious idea of pain. And I can see how it's out there. And sometimes my work is to support people to be like, hey, you know what? Pain doesn't treat pain. What if we stepped off the gas a bit? What opportunities would arise if you weren't doing those exercises all the time to the point where you were exhausted and you couldn't do the other things? And trying to sort of develop that person's own sense of this is what I can manage and this is too much for me today,
Mm,
and that's okay, and trusting their own voice rather than me saying that's too much, you now need to stop. Because that's the sort of, and I get where that comes from, and I respect people who use that, but it's just not the way I would do it. I would tend to try and um, as best as possible, support the person towards making their own decisions, even if I think, oh, I wouldn't do it that way. Like I like
mm,
the idea that people can make choices, even bad choices, right? Or even choices I wouldn't agree with. The point is for me to try and keep supporting them in getting from doing a bit more meaningful stuff tomorrow than they were doing yesterday.
mm,
Um, so I like the idea of using a 4 out of 10. I think that will require some calibration with your patient to figure out what that means and what that means to them. Um, but it could be 4 out of 10, it could be 6 out of 10. I don't know. It's just what is okay for you, and you're still able to have a good day and a good
mm.
week. Yeah.
Yeah, great. Thank you. Thanks, Sophie. Great question.
Nice.
Thank you so much for engaging.
Hmm.
And okay, so I'm just aware of time a little bit. We've got a couple more questions we want to get through here. So have you got any suggestions for practical language patterns or communication strategies to encourage movement without creating pressure or resistance?
Ooh, I guess, I mean, I've already sort of alluded to this, right? Like I spend a lot of time, I mean, I use a lot of values informed approaches because that's sort of the principle of acceptance and commitment therapy. So I'm really looking for people to say, this is meaningful for me,
Mm,
this is worth it to me, this is like I think you can't force or fake motivation, right? People either find something juicy and like, oh yeah, that's what I want, or they don't. And if they don't, you're likely to be setting, if we think about the physiology in terms of like pro-inflammatory and anti-inflammatory, like if they're not really wanting to do this thing and there's a likelihood that it's going to cause them pain, we're just not helping ourselves. So I tend to look for those kind of language patterns that this is something meaningful that look, I'm also looking for their non-verbal patterns. Like, does their face light up when they think about this thing that's important to them? Um,
mm,
and then also, like I said, I think agency is a really key process within managing living well with chronic pain. And I think if we look to the evidence as well, like, agency can sort of like correlate to changes in pain. So increased agency, reduced experiences of pain and vice versa. So even though we don't know exactly how or what is happening there, but like I think for me, the most important thing is that the person gets to figure out what can I do today, what can I work on today? And also, not necessarily just what can I work on, but like what would I like? What would I enjoy? What would bring me a sense of, congruency with my identity today, and focusing on
mm,
that. So yeah, I think that's it. Like, and remember that this is not necessarily a kind of a thing you do or a goal. It's a process of living that we're working on. So there's no
mm.
outcomes.
So
Mm.
we in our notes here we said what would feel possible today
Yeah.
is I really like that.
Yeah.
Yeah,
Yeah.
I really like that. Okay, so how would you handle a situation where a patient said, I've tried it before, and it made me worse?
Yeah, this is a really simple one. I would just believe them. Like, yeah, okay, great. That made you worse. I understood. Noted.
Mm,
Um, but then I would try and figure out maybe a little bit more about that situation. I would want to know. I wouldn't want that as I've got older and wiser, she says. I've got more aware of falling into the trap. Ah, but you haven't tried it with me, you know.
Yeah.
Like I think I definitely fell into that when I was younger. I was like, yeah, but I'm this, pain informed specialist clinician. You exercise with me is gonna be fantastic. And I think the reality is people know their bodies pretty well and they know their pain pretty well by the time they come in for you. If they're saying
Mm,
to you very clearly, if you give me more movement, I will have a shitter time and this will be harder, then I would just try to believe them and say, well, okay, can you give me some more context, some more information around what it was you were doing? If it was very exercise focused, then that gives me a lead in to think more movement based, more functional, more sort of like joyful activities based. But if it wasn't, then I might be saying, well, okay, if this is the level of activity you have now, how do we live with that? How do
mm,
we live well with that? Better doesn't necessarily always mean more. Sometimes better means like better managed might mean I am making better choices about the kind of activities I do. I am making space for the impact of doing more activities. I am able to forgive myself when I have a
mm,
flare up from movement. I'm able to be with my pain when it's more present. So sometimes I think the it's not necessarily always about getting people into doing more exercise because also let's not forget our evidence base is
yeah.
pretty weak when it comes to
Yeah.
that, when it comes to chronic pain, and especially if we've got fatigue, right? So the evidence for chronic pain might
Mm,
weakly sort of have this link that exercise reduces pain, but if you're looking at somebody with also chronic fatigue, the evidence there says something very different. It says if you enforce sort of like incrementally increasing exercise, you're going to make their fatigue much worse. So actually the opposite approach is more evidence-based within fatigue. It's about energy
mm,
management. It's about recognizing where you are, what sorts of stimuli or stressors take your energy from you. Well, we can do all of that in pain. What sorts of stimuli and stressors increase your pain? So I think we need to be careful that we aren't just sort of like tunnel vision when it comes to thinking about exercise and chronic pain. There's also a very strong moral judgment, especially in the sort of Western European cultures of healthcare, and especially since we had the sort of like obesity drive to get everybody moving and prevent obesity. Like there's a moral judgment that is set on people that they should be achieving a certain standard of exercise. But that
mm,
certain standard of exercise wasn't based on people with chronic conditions. So we have to be careful that we don't fall into a sort of ableist trap of like, actually judging and stigmatizing people living with a disability, with a long-term disability that does affect their ability to
mm,
exercise regularly,
mm.
because we haven't necessarily really recognized that some of those guidelines were not intended for the chronic pain population.
Cool. Thank you. Right. I've got a question from Sophie, and I think
Oh,
we can do it, but you've got like 30 seconds to answer it, Laura.
oh, there's a Q&A bit.
Yeah, there is. So again, Sophie, thank you. Fab question. How would you manage those with chronic pain such as fibromyalgia that have Achilles tendinopathy or plantar fasciopathy? I'm
Osteopathy.
not a clinician, excuse me, that require
Mm.
loading. Go on, you've got 30 seconds, Laura. Go, go,
That is
go.
it. Well, it's really difficult, isn't it? Right? It's really, really difficult. And also recognizing that fibromyalgia is systemic changes to how somebody's pain is being processed, right? So they're more likely to have higher levels of pain with new areas of injury or new areas of sort of pathology. So I guess I would also just try to incorporate these new areas into that overarching model of fibromyalgia. But I guess you just have, I think for me, I would go very cautiously,
Mm,
and also not necessarily hold myself to or the patient to the standard of rehabbing a tendinopathy in the absence of other pathology, because that's not what you're doing. You're rehabbing tendinopathy in the presence of pathology that we don't fully understand. So
yeah,
you and your patient should be held to that standard,
okay.
not something else, because this is hard and very complex. And
Thank you.
I'm glad that that person has somebody like you in her corner because it sounds like you are really engaging in that struggle. So
Yeah,
keep going.
thank you. Um, Quick wrap up, Laura.
Yes.
But if you want to what parting advice would you give to the people that have been watching today if they want to implement these ideas in their practice? Give us a practical tip for motivating exercise.
So first of all, I would look at your relationship with the word exercise and your relationship with the evidence base around that, and just ask yourself, am I understanding this through the lens of chronic pain, or am I using this in a general MSK sports post-op environment? Because I think that might be sometimes where we get stuck and where we sort of feel like we're failing as clinicians, or the patient is failing, or they're not motivated. And just remember that there is nobody more motivated than the patient in that room. Even if they look down, even if they don't seem to be sort of chomping at the bit for all of your information, they are absolutely desperate for their pain to change. The problem sometimes is that the way we see their path to change is not necessarily something that they're able to do in that moment. And so we're blaming motivation, but actually it's probably more complex than that. So be curious and focus on values and meaningful activities. It's really about doing more meaningful behavior than you were doing before. And sometimes that means doing
Mm,
less of what would be a traditional exercise approach. And
love that.
build trust and safety before pushing, or not pushing, that's not the right word. Build trust and safety before challenging any sort of boundaries, or and remember that the person has agency. A no is a no, and we are absolutely skillful enough to navigate around that in a creative way.
Amazing. Thank you so much. Thank you so much. So,
Yay.
Laura, as always, absolutely jam-packed. There's so much in there. For people that have been watching today, there'll be a summary of this emailed out to you. So don't worry if you missed, some of these key points. We'll summarize it for you, pull it all together,
Oh,
and it'll
lovely.
be in the show notes as well. So just briefly, Laura has got two Explain Pain courses coming up for those of you who might be interested in doing a deeper dive into these movement and motivation approaches. So Laura's just going to tell you a little bit about what you might expect from doing Explain Pain with her, because it will be different with Laura to any of the other teachers. So,
Yeah.
Laura, how, for people that have been inspired today, inspired by what you've talked about, how does an Explain Pain course look with you?
Yeah, so I think that's the important thing, explain pain, the way that we're teaching it is an evolved way of thinking about it from its original idea. And also the way I have been influenced by Explain Pain is to really recognize that this is a way, it's a pedagogical example. This is how we could change people's knowledge and beliefs around pain. And these are the sort of the principles and the processes that we're using, and they're sort of showing you and doing it with you all at the same time. So for me, when I think about what we're going to be looking at, it's going to be thinking about, like, how do we go about changing someone's belief system or thoughts in a way that facilitates, life getting richer and bigger.
Mm,
And em- like NP, neuropain science education is just one tool within what your huge amount of skills. So how does it,
mm,
not only how do I do this for patients, but like how does that integrate into my wider clinical practice? um, and what role does it play, and how might we be able to support someone towards movement change, movement engagement change through pain neuroscience education, and how might it get in the way, right? Because sometimes it might lead to people overthinking. Remember, this is a therapeutic choice. It's not like a standardized approach. We're thinking, how does this support this person on their goal towards living
mm.
well with their pain? So yeah,
Okay. That's
that's
amazing.
that's how I will be bringing it.
So, I mean, I'm sure I don't need to say this really, but Laura brings to her teaching a huge depth and breadth of understanding, um, completely cutting edge. Explain Pain is not a script, but you will learn how to use it with your patients. And if you want to spend 4 online weeks with Laura, then her online course starting at the beginning of October might be for you. You get to 4 sessions with her, you go away, you practice, you come back, for review and for
Mm.
mentoring with her. It's a phenomenal way of doing the Explain Pain course. Lots of opportunity for time with Laura, discussion, and truly understanding how to implement it with your patients. If you are in Ireland or in and around Dublin, she has got a face-to-face course in November. So do go and check these out.
Mhm.
Right. So thank you, Laura. Thank you
Thank you.
so much for sharing your expertise with us today.
Yeah.
And thank you to everybody for joining us in this clinical discussion series. We
And
hope you, what's that?
and for all the lovely comments, Laurie. There's
I
been such lovely things in the chat.
I
So that's
know.
also very nice. Thank you for that. Sorry.
Yeah, thank you. Thank you for your engagement. Thank you for your enthusiasm. Thank you for turning up week after week.
I know.
We absolutely love doing these sessions, and we're so thankful and grateful to be able to do them with you. So we
Yeah.
hope that you enjoy the rest of your day, whether that's the morning, the afternoon, or the evening. Take care, and we'll see you again really soon. Take care, everyone. Thank you
Bye.
again. Bye
Bye.
bye.